Good afternoon, everybody, and thank you so much for joining our webinar today on cultural communities and health inequalities. We're just going to wait a couple of minutes while everybody joins us. We'll get started in a few moments. Everyone is going to be placed on mute as they join us. And this webinar will be recorded and made available to all of you who have signed up and also on our webpage. We encourage you all to use the Q&A function for questions. And we'll have plenty of time for questions at the end, so do use that Q&A function. Without further ado, I think we'll get started. So I'm going to hand over to Minnie, our chair for today. Thank you.
Thank you, Ali, and a very good afternoon and welcome everyone. I'm Minnie Mangat, Head of Patient Engagement and Equality, Diversity and Inclusion Lead at Connect Health. I'm also an elected member of local government with a specialist interest in racial equality. So this series of Connect Health Change webinars, which have been running for, I think it's probably around a year, I'm sure we started in July last year, with the aim of supporting system leaders and clinicians across the NHS, providing debate and practical solutions to the challenging issues that we all sort of grapple with. Previous topics that have been covered include chronic pain, long COVID, psychology, service redesign, first contact practitioners, education, quality improvement and mental health. And all the past recordings, along with question and answer summaries, can be found on the Connect Health Change webpage. So today we are going to focus on cultural communities and health inequalities. That's what we're all here for. So with a particular interest in tackling health inequalities, particularly in diverse cultural communities. So we have a really impressive panel of speakers lined up with a broad range of experiences. And I'm really delighted that we have a strong patient voice today. 3 of our panel speakers will be sharing their own lived experiences with us, and we're very grateful for that. You can find full biographies of all of our speakers on our web pages. Each of the presenters will speak for around 5 to 7 minutes, and then that will be followed by an immediate question. And we'll take the majority of the questions at the end of the webinar when all speakers are finished. And I encourage you all to please post your questions in the Q&A box. So there are stark differences in health outcomes across the UK, with a gap of almost 19 years in healthy life expectancy between the most and the least deprived areas in England. Inequalities in power, money and resources, both at local and national levels, can make people's daily lives more challenging, and in turn this can make people more vulnerable to poor health. Unpicking the causes of ethnic inequalities in health can be challenging, but available evidence suggests a complex interplay of deprivation, environmental, psychological, behavioural and cultural factors. So the pandemic has brought health inequalities into sharp focus. Certain groups, as we know, have experienced disproportionate effects on their mental health as a result of the pandemic. Those from Black, Asian and minority ethnic communities have also been disproportionately affected. COVID-19 has shone a light on inequalities and highlighted the urgent need to strengthen action to prevent and manage ill health in ethnic minority communities. So in this webinar today, we're going to be aiming to cover the following. So for patients, how do we empower patients and the public to speak about their experiences and really listen and hear their voices and centre care around the people? For those delivering services in the heart of the community, how can we bring about appropriate outcome measures for people from different cultures? And for the third sector, how do we work better in partnership with patients from ethnically diverse communities? For service providers, How do we adapt physiotherapy, pain management and psychology services for different cultures? And for commissioners, how do we make sure cultural issues are high on commissioners' priorities? And how do we improve access to healthcare? So on that note, it gives me great pleasure to introduce our first speaker, one of our patient voices. Our first speaker is Sandeep Saib. Over to you, Sandeep.
Thank you very much, Minnie, and thank you Connect Health Change for having me today. It's a real honour and a pleasure. My name is Sandeep Saib and I'm here to provide my experience as a patient. Just a little bit about me. I've got personal lived experience with mental health. I was diagnosed with anorexia nervosa, body dysmorphia disorder and OCD back in 2014. And I've also had a suicidal attempt in August 2014 as well. And going through my overall mental health journey, bearing in mind I'm still on a journey of recovery and seeing therapists and so forth, I want to just explain my experience in relation to my mental health in the healthcare domain. And I started off with 6 sessions of cognitive behavioural therapy, which a doctor referred me on to, and was also prescribed antidepressants for 5 months. At that time, I was also on the waiting list for 7 months for the NHS secondary psychological care to start their 40 sessions. Between the experience of the 6 sessions of CBT and on the waiting list for the secondary psychological care, that's where my where my suicidal attempt happened and where my lowest point was. And it really spiraled out of control in all essence. And whilst I was waiting to be seen, bearing in mind obviously CBT sessions were completed by then, I started private therapy sessions, and it was mixed experience for me, because bearing in mind I saw at least 3 therapists in my journey to date, and none of them, I'm sorry to say, but none of them were of an Asian background. I am obviously I'm British, I'm Asian, I'm Indian, and I would have loved, looking back on it, to have someone that looked like me, to speak to somebody that was on my level to a certain extent and understand where I'm coming from. I think what Minnie mentioned from the outset, going through this pandemic with someone with so many identities in one human, you know, for example, me being a woman, me being British, me being Asian, all these different identities, you're dealing with very complex needs for that particular individual. And it's not a straightforward case. You've got to unpick each issue and find out what the core issue is in that person. And I didn't really have that connection with my therapists. I felt, looking back on it, that they tried their best and they did their job as best of their ability to try and understand from my perspective as much as they could. But I always felt, and looking back on it, there was something still missing. And I would just have loved to find someone that looked like me, that just understood, that was able to know the complexities of life that we are dealing with as people of colour, and find the relevant tailored support for us, whether it's a bespoke Asian peer-to-peer mental health support group, whether it's local Asian mental health charities out there. Nothing was pointed or recommended around those specific areas for me back then. Bearing in mind, society and healthcare and the mental health domain has now moved on and has developed. And I'm just pleased to say that there's been so many fantastic charities out there now, so many brilliant organisations from a local, regional and national level out there that are striving to focus on targeting mental health support and providing that for people of ethnic minority background. And I've definitely, going through what I went through and still going through with my recovery, I've obtained self-confidence, and I've obtained a sense of self-empowerment to put myself out there and find out more in terms of the help out there. And that's what I tend to do in terms of my advocacy work, to champion and be the voice for people of ethnic minority background for mental health issues, and do what we can together. And that's quite key. I think I just want to end it there saying we just need to work and continue to do what we do collaboratively together, because we are definitely making waves. Thank you so much.
Minnie, are you there, please?
Sorry, yes, I just had a little bit of an issue. Sorry, thank you so much, Sandeep. That was a really good insight, and thank you so much for sharing your personal experiences with us. And now I would just like to introduce our next speaker, again, one of our patient speakers, Jyoti Jadhav, over to you.
Hi, thank you, Minnie. Thank you for inviting me to share my experience today. Could we change slide, please? Thank you. As a physiotherapist, we're determined, we're thick-skinned, and we're quite strong. However, I had the most unexpected experience and the biggest challenge of my life. I was working hard and life was perfect for me until I started to feel weak and fatigued all the time. After 2 years of being in and out of hospital, I was finally diagnosed with having IgA nephropathy, where my body started attacking my kidneys. Next slide, please. Thank you. I was going through fatigue, weight gain, swelling, shortness of breath. I was emotional and had low mood. After 3 years of suffering, I had my best friend inserted into my abdomen, my peritoneal dialysis catheter. I was trained on home dialysis machine. I was dialysing 9 hours every night for 1 year. The pain it caused me every night, the drain pain, was the worst physical pain that I had to get used to. If I needed help, I could access the team 24/7. Normally it was around 4 AM in the morning when the tubes were blocked and I was dialysing, or I wasn't dialysing. Next slide, please. The one previous to that one, please. Thank you. Finally, I had that call, the gift of life call. My new organ, my kidney, came from a wonderful person who sadly passed, who has saved so many lives donating organs. Now that I'm a transplant patient, I'm still under the care of the renal team. It doesn't end. I'm living on 15 tablets a day for the rest of my life to make sure my kidneys don't fail on me. It's important for me to maintain my physical and mental health and well-being. Next slide, please. Thank you. This whole experience was new to me. I faced challenges in the community, pre and during dialysis. There was lack of awareness and knowledge in the organ donation, especially in the Asian community. People had fear of what would happen to them. It was taboo. People didn't speak about it. Some scholars and priests were saying religion doesn't allow for organ donation. People judged, for example, there's nothing wrong with you, you're being lazy, you're walking, talking and smiling, so you're fine. People don't realise kidney patients conserve energy for a task that's a challenge for them. I had monthly hospital checks for 5 years and I'm still under their wing. Next slide, please. Thank you. As a physio and as a kidney or a transplant patient now, I've learnt and experience a real patient experience. Pain makes you feel drained. It hurts physically and mentally. We go through highs and lows with emotions, mood and depression. All these factors play a part in this ill health, and that's why we have our mental health team that support us. Throughout this period, I was able to share and receive information from the renal team and my kidney friends about chronic kidney disease, mental health, nutrition, which gave me knowledge for my own self-management. It's so important to show a person they're not on their own, because there's a whole team in place from the NHS to social media that support us. It is scary, to be honest. We need a good supply of organs, tissues, blood to support people in need to survive a life through transplantation. We're always working with a medical team, support groups and dialysis and transplant patients or friends to improve lives. Change slide, please. I just wanted to conclude that raising awareness in different community groups increases the chances of finding an organ for people in need. Everyone should be made aware of organ donation, that giving a little part of themselves doesn't mean that they will be at a loss. They are sharing a piece of them to save a life. A live donor can choose to donate now or to anyone in need if they are a match. A deceased donor saves lives once they've been matched. Everyone who is involved with organ donation knows that mental health and well-being is key in this whole process. You always buddy up with a transplant or dialysis patient. Whether you're a donor or a recipient, you have support. Being on hemodialysis or peritoneal dialysis is a decision you make with your team, who is always supporting in your best interest. At the end of the day, it's a mechanical system in place to help maintain life until the real system is in place from donation. Thank you.
Thank you so much, Jyoti, for sharing your very powerful and inspiring journey. I wonder if I could just ask a question to you. I just think it'd be very interesting to hear. Have you made any changes to the way you carry out your professional physiotherapy role as a result of your experience of being a patient?
I think now that once you're a patient and you've seen your patients and how they are, and when you experience the pain, the mental health side of things, the treatments, going in and out of hospital, you actually, when you now treat a patient, you actually think about all those things, and it's more that you have a real connection with that patient. You're not just being a physiotherapist, you actually have this bond, you're supporting them, you're empathizing with them, you're educating patients. So there is a difference in this, you know, that you understand the realness of being a patient. It's not just, you know, you've learnt from a textbook and you apply it. There's a different way of now looking at things, being a bit more empathetic, a bit more softer in the way you approach things. So, yeah.
That's great. It sounds like, you know, that, you know, your experiences, you have sort of, you know, made changes to the way you carry out your role because you've been there, I guess. So thank you very much for your presentation and answering the question, Jyoti. So I'd like to introduce our next speaker, one of our patient speakers, who will share again some lived experiences. Naina Patel, over to you.
Thank you, Minnie, and to Connect Health for inviting me to speak. Basically, today I wanted to share my struggles as a mum and a carer to obtain support for mental health services for my adult son, who's 30 years old and has recently been diagnosed with psychotic depression. So, I mean, his problems with depression have been ongoing throughout his life. He has a pre-existing physical medical condition, which is quite rare. And I don't think, because it's so rare, the impact of it on his mental health in terms of the biochemistry of his brain isn't well understood. And I mean, I've done endless amounts of research to find out the connection between calcium and vitamin D on brain chemistry. But, you know, the medics here really can't really help me and haven't helped me as much because they themselves don't know. So my son's been experiencing depression intermittently over his lifetime. He's had endless amounts of trauma. He's been violently mugged because of his vulnerability, and bullied throughout his school years, and at university as well. But he is a very resilient young man despite those experiences. But unfortunately, one experience really set the course for his depression. He was bullied by a manager at a workplace, and it was unrelenting. And that sent him down into a downward spiral. So I watched him physically and mentally deteriorate over the past few years and desperately tried to seek help. I rang up the mental health team, and they said that they couldn't do anything unless he consented, and my son refused to give consent. I went to my GP practice and was turned away by the practice manager, who simply asked, "Is he drinking?" And I said, yes. "Is he eating?" I said, yes, but not much. Well, then there's not much we can do. And the reason I went to the practice manager was that I needed to see the GP to obtain help so she could access my son's medical records while I spoke to her about it, but I couldn't get past the front door. So, you know, my family has tried to organise private psychotherapy, psychiatry help, but again, my son was in denial and lacked insight into his condition and what he was going through. I also paid for a personal care assistant to come to our family home to chat and take him out, and again, my son refused to engage. So I felt powerless as a mum and as a carer, as both his physical and mental health declined. And in February this year, he was down to 4.5 stone. And I knew I would lose him. So I made that final call, which was to ring Adult Social Care Services. And I was pleasantly surprised to receive absolutely fantastic, sensitive, professional support from a social worker. So after she assessed my son with psychiatrists, she desperately tried to get him to voluntarily admit himself to the hospital, but again, he refused consent. And because his condition was so bad, he was eventually sectioned. But I have to say it was rather reluctantly by both myself and the social worker. And he's been in hospital for 6 months now. So the challenges I've faced as a mum and as a carer are not new. As a parent, you feel helpless. I'm sorry. I am trying to hold it together, but you can see the illness, but the person with the illness can't, and therefore does not consent to receive help. So every day for the last couple of years has been tinged with sadness, absolute desperation and despair as you see your adult child deteriorate. Yet services can't step in until he consents, or like the GP practice are simply dismissive. And I have a background in mental health research. I've interviewed countless of people with mental illness, mental health problems, adult services. I did a stint in the local CAMS service. So I know how to navigate the system, but you know, I just felt helpless, and I just feel that something needs to change, that the system needs to listen to carers' concerns. So I'll leave it there, and I'm happy to take questions.
Thank you so much, Naina, for sharing, you know, what is a very difficult story for you to tell. I can see that. So we really appreciate you sharing that with us. You know, you're a very powerful voice for parents and carers, and I'm sorry you've had such a challenging time of trying to access care for your son. And I wonder if I could ask you a question. What advice do you have for other parents or carers that may be in your position?
I think you have to continue knocking on doors. And, I found social services absolutely fantastic. I mean, the social worker had said to me when I first rang her that she was just hoping to send intervention services in. And maybe had I tried that earlier, but I know that had I done that, he still would not have consented because of his particular illness. He had a particular set of beliefs. So I think it's just keep knocking on doors. And, if it is as desperate as my situation was, you do have to think about sectioning. It's not something I've heard horrible things because I've actually researched sectioning in the black communities, in South Asian communities, and it was not a step that I took lightly at all. So, keep knocking on doors.
That's great advice. Thank you so much, Nina. We really appreciate you sharing your story with us.
Thank you.
I just like to introduce our next speaker, who will be talking about tackling stigma, diversity of voices and recommendations and best practice. I'd like to introduce the chair of the South Asian Health Action Charity, Kirit Mistry.
Good morning. Thank you, Minnie. Thank you for inviting me to come and share some of the work that we do. But firstly, a big thank you to Jyoti, Sandeep and Naina, who are privileged to be working with, and really as powerful lived experiences that they've shared. They're the people who can really change hearts and minds, and obviously that's the way we work as an organisation. So next slide, please. Next slide, please. So just quickly, I'm going to run through a bit about the organisation. We were formed in 2017, and we're a patient carer and community-led charity, really there to listen, understand and advocate the needs of South Asian communities from a lived experience. Next slide, please. We're structured from a board of trustees, but we have our main focus is having the premise of community ambassadors, people with lived experiences, as you heard today. So we've got our SAHA community ambassadors who are patients like myself with diabetes, kidney disease, organ-related transplants. We've got our latest project, which is South Asian Community Mental Health Ambassadors, as we've seen a huge rise in mental health challenges with the pandemic. So we've created a pilot project in Leicester. And as we're a patient carer-led charity, we need to work with medical advisors. So we have a team of SAHA medical advisors who can support us. So we can actually get that professional medical support. Next slide, please. Again, it's about raising awareness of major health issues like diabetes, kidney disease, organ donation, and mostly it's about collaboration and working with the lived experience patients, communities, carers, and healthcare professionals. Next slide, please. Our kind of vision is really around engaging, so we really need to create discussions within the community to facilitate change. As we've heard from Naina, there's stigma within certain conditions, so we really need to engage and change, get people to talk comfortably. We need to educate, we need to kind of get people aware of what support is available, and work on a one-to-one or even on a peer level basis. We have to empower people to feel confident and develop the skills, but they need the support. The empowerment comes from building confidence, and that's clearly how we also work. And finally, one of the gaps I was seeing was that research organisations were not having people with conditions like coming from a diversity point of view. So we've started to look at how we can explore working with research and medical charities to ensure the patient voices are there. Next slide, please. Some of our current projects, as I said, as a small organisation, a lot of the doors were closed for us because NHS and other organisations really blinkered in terms of wanting to work with on a culturally sensitive basis. So I think setting up South Asian Health, but we realised that collaboration was the way. So these are our projects that we're currently working with. We're working on stem cell surveys with targeting South Asian stem cell patients with Anthony Nolan. We're working with Equality Health, the research company, to look at getting community partners to be involved in shaping research. But the powerful breakthrough has been working with National Voices, a national healthcare charity with over 300 health and social care organisations, but realised that they were lacking diversity and inclusion expertise. So hence, working now with them on a long COVID project and trying to get South Asian voices. Next slide, please. So that's just a flavour of some of the stuff that we've done around the pandemic, but also around targeting specific conditions. And I'm going to move on to the next slide because they're the next 10 points I want you to take home with. So look, clearly my journey has been, as a patient, as a carer, it's been hard to actually be engaged. So I have to start knocking on doors locally with CCG, regionally with various institutions, and nationally. So one of the clear things I'd like you to take home is look at your, ensure you have a clear plan, reviewing your current organisation is key to look at what is the diversity and inclusion look like in terms of your patient carer voices and communities. So go back and think about that. Secondly, it's about being culturally competent, when engaging patients, carers and communities from different cultural backgrounds. Do you have an understanding about where they're coming from and some of the barriers that they go through? Thirdly, you need to tailor your engagement to the audiences you're trying to reach. People lived experiences, as you've heard today, are the key messengers. So you need to get them on board. The fourth point is go beyond this kind of one-size-fits-all approach. It's key to avoid, sometimes we fall in the trap of tokenism or ticking the boxes. I think that's something that we've got to try and move away from and look at building better relationships. The fifth point is we talk a lot of, I hear it, co-production, co-design, but really that tends to happen as an add-on. We need to look at how does it impact from the start and how do you ensure effective involvement right from a blank sheet of paper is where you start your co-production, co-design. Next slide, please. You need to value the contributions of people who are helping you to engage. So sometimes funding is going to be a challenge, but you need to look at how you recompensate that expertise, that lived experience expertise. And again, it's about, you can only recompensate, but think about having a little budget to pay people's time and contributions from people with lived experiences. Providing training, mentoring, support, is key. It's like we need to look at, sometimes people lack confidence, they lack the engagement. So really providing that support to get them to be more engaged with you and what you're trying to do as an organisation. But they do need that mentoring support. And sometimes that mentoring support could come from people who you've managed to get on board from various lived conditions, and they would then mentor and buddy up that person to give them that additional support. Don't reinvent. There are a lot of models of good practice. The key is about collaboration, and now you've come across an organisation today like ours who we're happy to collaborate. Finally, last two points is we need to create a safe space to enable people to be valued. Not just token them, value them, treat them equally. Treat them as part of your team, as professionals, or as a team member. Forget the professionalism, but treat them equally is key. And finally, we've got to change the way commissioners fund, the way commission services. A lot of it's done on a kind of a ad hoc basis or on a friendship basis. It's the usual suspects getting the commissioning, getting the contracts. And what we need to do as patient carers and communities, we need to be knocking on those doors, but working with organisations who are listening today to work with us in a collaborative way to ensure that the end product, end service users, end communities who get the delivery of that service is of quality, of cultural competence, and of an equity basis. Thank you, and sorry if I've taken more time than I should have.
Thank you so much, Kirat. it's great to see some of the projects and collaborations that you've been involved in and a key part of. And thanks for the useful messages of sort of best practice with your 10 key points. I wonder if I could just ask you a question. Is there anything else that you would add to sort of say, how do we truly get leadership teams in all organisations to represent the populations that they serve?
Well, I think this last 18 months has given us a real challenge around getting. With George Floyd, I think we've got racism and race back on the agenda. So I think a lot of organisations are now trying to look at how they can be more equity in terms of their workforce, how they can be engaging more in the communities. But it starts from leadership and people. You can't. It's just not one person trying to drive this. From the board level, we need to see more diversity on the boards, right, and people with lived experiences. From a workforce point of view, we need to see greater people from our communities coming into these kind of professions and taking up roles within those organisations. But it's about forward planning. So if an organisation is wanting to recruit, it's about forward planning that recruitment strategy and drive to hold information days to enable people who may not be applying for these roles to better understand what you're looking for as an organisation. And finally, I think really it's about this collaboration. We have to, organisations have to collaborate with specialist organisations. There are a number of race equality organisations. There are a number of national charities who could help organisations. But you've got to be honest with yourself. You've got to have that internal safe dialogue first and conversation in your organisation before you can then think about going out publicly to say, yeah, we're failing on our diversity, we're failing on our equality strategy law, we're failing on working and engaging with protected characteristic groups. Once you've had that internal dialogue, then you've realised that you need to do more, and then that's the honest dialogue with organisations to take that work forward. But I think it's about doing that internal review and then working from there and creating a clear plan of action.
Thank you, Geereth. That's really, really useful advice. I think, what you're saying about sort of collaborative working, we can certainly, achieve a lot more together than we can independently. So thanks for your presentation. Just going to move.
I think you're on mute.
Sorry, can you hear me?
Yes, we can hear you.
Okay. Did you hear what I'll just repeat what I just said, really. Just wanted to say thank you to Geereth. That was a really, really useful presentation. And, the message about collaborative working, we certainly can achieve more together than we can independently. So thank you very much. So moving on to our next speaker, who will be talking about culture and pain and improving access to services. And I'd like to introduce Mohammed Shoaib, who is our clinical lead in Huddersfield and North Kirklees here at Connect Health Pain Services. So over to you, Mohammed.
Thank you. Thank you very much. And thank you for organising this webinar this afternoon. Thank you so much. So yeah, I just thought I'll share some insights on some research we initially did many years ago in West Yorkshire on the influence of a patient's culture on their pain perception whilst I was working in a physiotherapy department in West Yorkshire, and how that influenced then some research, and then how the research has translated into some real world clinical change in practice and service delivery. Next slide, please. So first of all, in terms of culture, what is culture? If you look at kind of the definition in the kind of journal articles, textbooks, if you like, it's defined as a set of learnt behaviours, beliefs, attitudes and ideals that are characteristic of a particular society or population. But then translate that into healthcare behaviour. Culture has a vital influence on the illness behaviours. So how you behave when you're unwell and when you're well can be very different. The healthcare type of practices you seek out, and therefore help seeking activities you partake in, and your receptivity to medical care interventions. So from a cultural perspective, looking at kind of how pain is managed within physiotherapy, MSK, orthopedics, pain management, rheumatology as such, one of the most common questions to ascertain a patient's pain score is asking them to rate their pain on a scale of 0 being no pain, 10 being the worst pain ever. And even despite using an interpreter if the patient's first language is not English, even then the patient may struggle to provide a simple numerical answer, because in some cultures around the world, ascribing a subjective pain experience to a number is a completely alien and bizarre concept. And that really kind of led me on a journey over the last couple of years to try and understand and unpick this a little bit more. Next slide, please. So we've spoken about what culture is, and hopefully we've broken down what culture is in its terms of its kind of definition and in healthcare, but then bringing that together into the context of pain and pain management. Believe it or not, last year, the International Association for the Study of Pain, which is kind of the world governing body for pain research, revised their definition of pain, again, some 40 years on from the last definition. So pain is now defined as an unpleasant sensory and emotional experience associated with or resembling that associated with or actual or potential tissue damage. That's the actual definition. But then if you look further down on the 2020 revised definitions of pain notes, the one in the bottom left corner, through their life experiences, individuals learn the concept of pain. And that is the most important one when we're working with patients who come from different cultural backgrounds, different countries, different parts of the world, and are residing in the locality you're working in. People learn the concept of pain, their perception of pain and how they express it, if at all, is learned through life experience. So how they were brought up, the way their life journey has led them to be, has a very powerful influence. Next slide, please. So we know from research, again, the cross-cultural investigations looking at different cultural groups and societies, that the definitions, the descriptions of the words people use to express their pain and the perceptions of pain and pain control are culturally specific. So one cultural group that maybe have one injury and another cultural group has the same injury, they may express the pain and feel the pain in very, very different ways, use different words to express the pain. The way in which pain is experienced is powerfully influenced by culturally based attitudes, beliefs, and values. Beliefs and values mediate emotional responses to pain disorders, and that could be the pain coping strategies. And in some cultures, they express a high level of stoicism and resilience. Some are reliant on lots of spiritual coping strategies. Some cultural groups often have a high degree of hypervigilance or catastrophizing. So again, patients from different cultural groups can express pain in many, many different ways, and it's very nuanced, a bit like a fingerprint. Next slide, please. So, time to pause and think. So we know that's the research. If we know that people from different ethnic and cultural backgrounds experience persistent pain differently, then why is it that everyone is expected to respond to the same treatment in the same way? i.e., if you've been referred to a pain management clinic and you've been assessed, that why is it then that every patient should undergo exactly the same treatment? And it's given the answer away there. So the research shows that self-management, or in its expansion here, extrapolating onto long-term conditions, the self-management approach is considered to be a Western cultural construct, and it's born out of a Western principle and management approach. Next slide, please. When we look at health inequality, so there's been some brilliant work by the King's Fund last year at the start of the pandemic, looking at health inequalities. Health inequalities are avoidable, unfair and systematic differences in health between different groups of people. And if we look at the two areas in red, which is exactly what this webinar is all about, to try and break down the barriers and improve patient levels of satisfaction. Next slide, please. So cultural adaptation, then, looking at the research, how we convert that into a change in clinical practice. Cultural adaptation is defined as the systematic modification of an evidence-based treatment. In this context, it was a pain management program for patients to consider language, culture, and context in such a way that it is compatible with the patient's cultural patterns, meanings, and values. Next slide, please. So, ways to make things more culturally acceptable, allowing more time for explanation, ensuring that the patient is heard, expectations are discussed at the outset. Patient education is paramount, and I'm sure this has been kind of mentioned earlier on today, particularly in regard to challenging externalized beliefs, adaptive coping strategies, and discouraging the maladaptive ones. And again, in some cultures, there was a perception of daily demands related to the cultural expectations of women within the Indian research group. These researchers looked at, and this was viewed by some as a barrier to self-management. So how those cultural concepts can be broken down. And like it says in red at the top, better communication, greater understanding to try and break those barriers down. Next slide, please. There are some other helpful tools that the attendees today can use. Again, breaking barriers, building bridges, and I'm more than happy to share these resources that you may wish to use with patients that you work with within MSK, rheumatology, pain, orthopedics. Next slide, please. So, in conclusion, culture may influence the acceptability and appropriateness of treatments designed to impact cognitive and behavioural changes. As a result, treatments that have been developed by clinicians in one culture may not necessarily be relevant or effective in another culture. Such treatments may need to be adapted in order to maximise their efficacy when used to treat patients in a new culture. So again, moving away from this one-size-fits-all and getting to understand the cultural group you're working with and adapting, tweaking things to make it more acceptable. Thank you.
Thank you, Mohammed. That's some great work that you've obviously been involved in, and thank you for sharing those insights with us. I wonder if I could just pose a question to you. Yeah. I mean, how do you think that, you know, we all get better at listening to ethnically diverse communities and improve outcomes for all?
I think really it's, again, at a service delivery level, kind of looking at maybe feedback or where there's gaps in provision. So, for example, if a certain treatment modality is only provided to patients in English, yet the local population is, say, 80% non-English, well, then there's a clear gap in the service provision to try and improve the acceptability and access to patients in that local region. So I think it's knowing what your local demographics are and looking at kind of what service provisions is currently and if there's ways to improve things. And I think moving forwards, technology has really allowed that to accelerate quite a lot by having access to online mediums such as audio material, video material, which we didn't really have a couple of years ago. So that's really helped patients, particularly in certain cultures and certain groups in which patients are unable to read English or their own native mother tongue language. If they can't read, then having audio or video material to get that patient education and information across really helps them to break that barrier down.
That's great, really useful tips and advice there. Thank you so much for your presentation and the answers to the question. Thanks, Mohammed. Can I just remind everyone, thank you for your questions so far, but please do keep them coming. And now I would like to introduce our next speakers from Health Watch in Hertfordshire. So both Jeff and Priya will be talking about how to listen to ethnically diverse communities and improving health outcomes. So I'd like to introduce Jeff Brown and Priya Vithalingam. Over to you.
Thank you very much. I'm just going to do a quick introduction to what Health Watch is about, and then hand over to Priya, who's going to talk about the research we've been doing with ethnically diverse populations. Next slide, please. And the next one. So for people who don't know what Health Watch is, there is a Health Watch in each area of England. There are 150 Health Watch nationally, and our role is to be the independent consumer champion for health, public health and social care. And a lot of the work we do is in partnership with community organisations, other voluntary sector organisations and so on, to ensure that the voice of patients and communities is heard. And hearing previous presentations today, the importance of carers is fundamental to us, as it is obviously to people within health and social care. So what we do really is to provide evidence to improve services and health and well-being. We do it across Hertfordshire, and other local health watch obviously do it within their patch. And we provide a signposting and advice service where people could contact us. They might tell us about their experience within health and social care, whether that's good or bad. They might come to us to see what to do next to deal with the problems that they're facing. And again, we would have been there to help people with the sorts of issues that have been raised today, the challenges people have faced. And what we do with that information is to feed it back to providers, to commissioners with health and social care, and we generally those organisations are generally responsive to what we're saying and look to make improvements to make services better for patients, for service users. And just to touch on a specific example of that, working with Connect and the MSK services that they provide in the west of Hertfordshire, we'd had feedback from patients about some bits of the service, some bits of accessing the service that weren't necessarily working as well as they could be. We fed that information back to Connect. There were some very positive responses there, and service changes that were put in place. And we then used some of our volunteers to do mystery shopping to see whether those improvements had worked in practice, and we got some very sort of positive feedback to pass back to Connect, and I guess also some useful things for improving services yet further. But it's an opportunity using your local health watch to give that feedback, perhaps if services aren't being as culturally sensitive as they should be. Health Watch does have a statutory duty to help tackle health inequalities, and that's across the whole range of health inequalities. And this year we've done work with people with learning disabilities about their access to their annual health checks, the quality of those health checks, who was getting them and so on. And again, made recommendations to the NHS to improve those, and we're monitoring progress there. We've done work with veterans and veteran access to healthcare, what's working well and where there are concerns, issues of stigma, for instance, with it for the veteran community. And we've also been, during the pandemic, looking at people who are digitally excluded, particularly as more and more services are provided virtually. And finally, and again, linking to what's been said before, we've been doing work in some of the most socio-economically challenged areas of Hertfordshire, and it isn't all sort of nice and home counties, and particularly looking at building confidence amongst young people within that area. That's all from me. I'm handing over to Priya, who's going to talk particularly about our work with ethnically diverse communities.
Thanks, Jeff. So next slide, please. Excellent, thank you. So as Jeff just mentioned, in terms of the most recent project then, earlier this year we launched 2 surveys with the Hertfordshire population, one looking into attitudes receiving the COVID vaccine and the other looking at experiences of people who'd already received 1 dose of the vaccine. We found that so over 1,800 people responded to our surveys, but found that there was a limited number of responses from ethnically diverse communities. So in response, we scoped research aimed at better understanding the views and experiences specifically within Black and Asian communities. In terms of what we did, we conducted an evidence review, mapped relevant community and voluntary sector stakeholders, and then conducted 2 rounds of one-to-one discussions. The first one being broad discussions aimed to understand vaccine confidence and barriers, and then round 2 being tailored questions aimed to better understand differences and similarities between the different groups and communities. And then after that, we held a stakeholder consultation event to collaboratively scope the way forward and also present back the findings that we had heard. Next slide, please. So I'll now talk about some of the themes that emerged from the stakeholder engagement. Some of the themes we found were common between groups, and some concerns were raised by specific groups. So as I go through the list, what I'll do is I'll differentiate between the different groups and concerns where appropriate. So with the first bullet point then, in terms of effects of isolating language, so what we know is that language and terminology is really important. We're aware that BAME is an unhelpful term as it homogenises very diverse ethnic groups and encourages a single solution response to very complex issues. And we also know that the term, or what we found, is that the term vaccine hesitancy can also be quite unhelpful, as it doesn't encompass the complex issues that lead to reluctance to take the vaccine, as well as ignoring things like access issues. So what we've tried to do, and I guess others have here as well, is we're looking to use terms like ethnically diverse groups instead of BAME and vaccine confidence instead of vaccine hesitancy. Moving on to poor experiences of news and media, what we found across all groups was that communities felt targeted by the media and found the approach used sometimes inappropriate and sometimes with a racist undertone. An example of this was that ethnic communities felt scapegoated, particularly at the beginning of the pandemic, and felt that media reports blamed these communities for the spread of the virus due to living in multi-generational and sometimes overcrowded homes. Another example was the use of celebrities or MPs of ethnically diverse backgrounds in the media, and criticisms here included that people did not necessarily represent them or their lived experience, and so it can feel quite manipulative and tokenistic when using celebrities of the same colour but don't necessarily have the same lived experience. Moving on to concerns around sort of side effects and safety, common across all groups was that there were concerns related to side effects and questions on what long-term effects of the vaccine may be. Sometimes these questions and concerns related to mistrust. However, what we tended to see was that responses to the concerns had a tendency to be myth-busting in their approach rather than looking to build trust and understanding. So that could be an area that could be better. Moving on then quickly to socioeconomic and cultural factors. So here we look to investigate whether a lower uptake of vaccine is due to supposed hesitancy or access issues. With regards to socioeconomic factors, we found that concerns were raised specifically by the Black community relating to the flexibility of vaccine appointments and the financial aspect of having to take time off work. So if people who work in frontline roles or do shift work simply can't afford to take 1 or 2 sick days due to the side effects, then not getting the vaccine may be an issue of access rather than hesitancy. And at the time of the research, groups told us that vaccination clinics were not in ethnically diverse neighbourhoods, and often people had to travel some distance. And this was particularly interesting for us because this was different to what we had found in the main surveys, which tended to be generally sort of the white British population, where they told us that vaccination centres were pretty easy to get to. In terms of access to information, there were concerns that sometimes information isn't easily accessible, particularly if it's not provided in a safe community space, which has been referenced by other speakers. And for us, when they talked about a safe community space, they described it as a place that is familiar and used by people of colour, but also a place where people feel comfortable to ask and answer questions openly without fear of judgment or being labelled as anti-vax. And with regards to cultural differences relating to gender, age and family dynamics, examples here were of matriarchs of South Asian families being more likely to be more concerned with their family's health over their own health, or women of certain religions worrying about their modesty being compromised in open-spaced vaccine centres. And then moving on to choice and control, this broadly relates to people wanting to have the choice to accept or refuse the vaccine without feeling pressured or coerced. Different groups felt differently about this and have different motivations for wanting choice and control. So, for example, Black communities, the issue of choice tended to relate to historical treatment, long-standing issues of trust and mistrust, but also more recent personal experiences with health services that they had experienced. And in comparison, for certain faith groups, choice and control related more to ensuring the vaccine didn't compromise their religious beliefs. So what I'll do is I'll just summarise the last 3 bullet points quickly, which is just that ultimately we found that different groups have different histories and experiences that feed into their feelings towards the vaccine, which is unsurprising. And for example, issues of trust need to be treated differently in regards to different communities. Feedback and literature suggests that South Asian people are usually quite trusting of healthcare professionals. However, Black communities, we can sometimes see a mistrust in the government that filters down into the NHS, which highlights the need for specific tailored communication as well as interventions, which again has been highlighted already by previous speakers. Next slide, please. Thank you. Is it the next slide? Oh, thank you. Yes, great. So I'll quickly whiz through this in the next one then quickly. So in terms of what the stakeholders told us, so what they stressed is that for effective engagement, we need to recognise, and we're looking at our area in particular, that there are challenges to representation with patient public groups and research and engagement. And linked to this, they wanted us to recognise that complexity and variations between different communities and groups, and the pitfalls of seeing Black and Asian communities as one homogenous group. They discuss the frustration and perception that these communities are sometimes only engaged with when the agenda suits the government or the NHS, and that's particularly at the moment with regards to the focus around vaccine take-up. So what they're talking about here is that there has been health inequalities before COVID, and so why are they sort of being targeted and listened to more now? And they would like, they would hope that this would continue sort of post the focus on the vaccine uptake. They talked about challenges to the infrastructure, so community groups running on volunteers and goodwill and sometimes not having funding. And they talked about need for better understanding of the issues before developing solutions. So they said, sometimes solutions just tend to come before that understanding, and so felt that the understanding was really a crucial first step. And then lastly, they talked about the need for better connections across community groups, more visibility for organisations like theirs in order to aid their ability to influence. So just moving on to the last slide. So what this helped us do is think about designing an inclusive engagement model locally. And so the findings from the engagement tell us that in order to have a sort of meaningful, inclusive engagement model, what we need to do is we need to utilise the knowledge and skills of community groups and leaders, but also recognise their challenges. So in terms of that sort of funding. We need to look to better understand challenges and issues by building a stronger, more robust evidence base before co-designing solutions. We need to look to better understand and address short-term barriers to the vaccine, but crucially, we need to engage around health inequality more generally and listen to people around that. We need to build trust within communities through continuous engagement, tailored to their different challenges and concerns. So a key finding or a key bit of feedback was sometimes research and whether it's from the NHS or from other organisations can sometimes parachute in and then parachute back out, and they're looking for something that's much more meaningful than that. Challenges around disengagement by ensuring communities can influence change. They wanted, in terms of a good engagement model, it's about raising the profile of communities that are seldom heard and the organisations that represent them, and health issues and concerns of Black and Asian communities are represented at every level. I'm so sorry that was really fast. I was just trying to get through the time, but that I'll end it there. Thank you.
Thank you, Priya and Jeff, and thank you for whizzing through that. Some really great insights into the research that you've carried out. Unfortunately, there's no time for questions now because we are sort of running behind slightly. So I am going to move on to our next speaker, who is Professor in Diversity and Public Health and Director at the Institute for Health Research at the University of Bedfordshire. Professor Randhawa will be talking about tackling health inequalities, a journey to partnership working. So over to you, Professor Gert Randhawa.
Thank you very much, and it's a real privilege to join this conference and speak after such amazing talks, especially from the patients. So next slide, please. So just to sort of emphasize, I do want to talk about journey, because I don't think you can have partnership working which sort of happens overnight, and also it's not a static process, it's a very dynamic process. It requires investment, it requires patience, and it requires commitment. Next slide, please. So just a bit about the Research Institute. We're committed to doing applied research, but also our curriculum is also about embedding research into our teaching. Next slide, please. We take a life course approach to all of our research. So we do studies all the way from preconception all the way through to end of life care, and that includes all different ethnic and faith communities. Next slide, please. And this is just our mission statement. We're genuinely interested in patient experiences, patient journeys, staffing issues, but also the structural issues that impact upon health and social care. Next slide, please. And we've got a number of research centres that tackle all of these, and I've got some amazing colleagues who lead these research centres. Next slide, please. I'd just like to share this purely because at the moment, because of all the restrictions, we sometimes forget where we work. So I'm really lucky that although I'm based at University of Bedfordshire, my campus is actually within Hertfordshire. It's a place called Puttridgebury. So if you're ever driving from Hitchin to Luton, you're welcome to step by, and you can normally find me walking the grounds with my PhD students. Next slide, please. So I just want to talk a bit about the whole debate about health inequalities. So firstly, I don't think there's a debate. We know there are health inequalities, we know they exist, and we know that there's ample evidence that this exists between ethnic groups, within ethnic groups, and a lot of it is also linked to social class. And I just am a firm believer that we don't need to commission any more research evidence on this. We need to crack on with action, which is pretty much what every speaker said. Next slide, please. So just to illustrate my point, I've spent 12 years as a chairman in the NHS as well as a researcher for over 20 years. I've lost count of the number of reports that say there are health inequalities based on ethnic and social class diversity, and there's lots of recommendations. The challenge is there's no accountability for implementing those recommendations, and therefore nothing ever changes. And we've seen that now with COVID. We're just repeating the same mistakes. Next slide, please. So I think, you know, as we sort of go forward, we've got to learn from a lot of the current issues which sort of link between social class and ethnicity. Next slide, please. In the interest of time, I'll skip that slide too. So we've got lots of studies, but just for this audience, I just want to focus actually on the one that's marked in red, and I'm happy to share my slides. So this is a study to do with consanguinity. So this is cousin marriages, a very sensitive topic, but a lot of the children who've been affected from consanguineous marriages sometimes have health and social care needs, and a lot of them are in need of musculoskeletal or physiotherapy services, and a lot of local authorities across the country are grappling with both the human and economic costs of this. And what I say is, if you're going to do research on these sensitive topics, you need to do it in partnership with communities. So when we designed this study, we work with local community leaders, local councillors, local religious leaders, firstly to design the study, then to ensure that people felt safe and trusted in sharing their experiences. And on the back of that study, this was in Luton, by the way, we were able to launch, in partnership with the local authority and the public health team, a service called the Know Your Genes service. So that's a very culturally neutral term, because that means that everybody then has the opportunity to access genetic counselling if they wish to do so. And I think that's one of the things for me is that if we really want to develop a programme for tackling inequalities, we need to find a way of giving voice to those people who don't have a voice, so that they genuinely have informed choices. And there's a whole set of studies listed there that go from sort of childhood to mental health, etc., that we've done. Next slide, please. That move on to then our work on cancer, organ donation, end of life care. But I haven't got time to sort of share that with you today. Next slide, please. But what I want us to think about is, and I think we all need to look in the mirror, including us as a university, is about how do we solve some of these structural inequalities? Because if we don't have at senior level diverse staff, and even at a sort of middle grade level diverse staff, then why do we expect our policies, our priorities be any different? And I think fundamentally, until we start to tackle these structural problems, everything else is tokenistic and lip service. Apologies if that sounds a bit blunt, but that's what the evidence base shows, that, you know, you need diversity at the top to change the sort of strategic direction of any organisation. And then what you tend to see is, for example, in my world, you'll tend to then see, for example, research funding that will start to be thinking about issues around health inequalities. So, for example, at the moment, the biggest funder in health research, National Institute for Health Research, quite up until very recent months, was quite happy to fund studies that never included non-white communities, and that was seen as quite normal, which is quite shocking when you think about diabetes being far more prevalent in South Asian communities and African Caribbean communities, as is high blood pressure. So I think, you know, we've got to hold a mirror to ourselves as organisations. We do a lot of work, for example, on workforce diversity, and the only way we're going to recruit from communities is if we start to go out to those communities. So, for example, as a university, we're moving away from university open days. We're holding now community open days so that we go to communities. Communities build trust with us, hopefully believe in us, and then we ask them to come and visit the university if they're still interested. So I think, as I said at the beginning, it's a journey, and I hope that many of you are interested in going on that journey. Next slide, please. Thank you very much, and happy to take questions.
Thank you very much, Professor Randhawa. That's some great insights you've shared with us, particularly like the practical example of tackling health inequalities with the Know Your Genes service. I think that's really interesting. And I wondered if I could just put a question to you. What are some of the challenges of partnership working in tackling health inequalities?
I think actually Kirit put it better than I did. I think the problem is that there's a rhetoric around co-design and collaboration, but what tends to happen is providers in public sector, voluntary sector, they tend to have a model in mind and then consult on that model. That's not co-design. Co-design is starting from a blank page, and I think the challenge is providers feel a loss of control, and they feel nervous about doing this. And the best example I've seen this work is if I'll put you in the direction of the community investment scheme, and that's related to organ donation. I can send the link if people would like to see it. So that's 50 community-led projects, community design projects, all across England amongst diverse ethnic and faith communities, where community organisations have designed their own projects. And I have to be honest, that's been quite a nervous process for NHS Blood and Transplant, because they've had to relinquish some of their brand messaging, because we all love a brand, don't we? And we all love our logos and our colours, etc. And they've had to relinquish all of that, but it's worked because they've now got trusted messengers, tailored messages, and people are engaging with that conversation.
Thank you. Thanks very much. Thank you to all of our speakers. We have a few minutes now for some questions that have been put in the chat. So I'll start with giving this question to Sandeep. What tips would you give others in your situation?
There's many tips, to be honest, Minnie, but a few that jump to my mind is not giving up, and having, I guess, self-hope in yourself. I think it's great all in well that we've been exposed or had help or are looking for help in the healthcare domain here, but we've got to really look at ourselves, and we are our own best therapists at the end of the day. So we've got to think about self-hope, self-empowerment, and start from there first, as much as we can. So really look within yourself and see what you need to do to help yourself before even helping others and taking that step. That's the biggest tip, I would say. And to not lose hope. And lastly, please continue to talk and use your voice and feel like you can do so to amplify that. I hope that's helped.
Thank you very much, Sandeep. The next question I will just put to Mohammed. How could we help physio undergrads appreciate the experience of suffering to help them be more empathetic and effective?
Hi, enough. Thanks, Minnie, for the question. To help students become more empathetic, I guess that will really come once they start their 100 hours of kind of clinical placement experience, and they get to see kind of that first-hand experience of patients in pain on the ward or in whichever clinical setting they may be placed into, for them to then begin to help open up their eyes. Because for some students entering university, they may have entered university, say, at the age of 18, 19, and then within a couple of weeks they can be launched into a placement, and that can help give them some insights into kind of how pain is, perceived, how it's expressed, and then that can then be reinforced with the kind of academic units and modules. And again, there needs to be a greater focus on the undergraduate curriculum around cultural awareness or cultural competency, about how the differences are and how they should then be able to bridge those gaps with patients. And again, that will then further be improved as they go from year 1 to year 2 to year 3 and they graduate into the real world.
Sure, thank you very much, Mohammed. And just one more question. I think if Kirit, you could take this, that would be really useful. Are there any specific stigmas in your culture that worsen situations, and how can you overcome stigmas?
Yeah, sure. So I think the current one we're tackling is mental health, and that's been around for many years. And obviously, not wanting to people keep the issue in their own four walls, and not wanting to let others find out. And I think the only way we can do that is have more messengers. Sandeep is one, but we've created this ambassador, community mental health ambassador. So people trained to be in the community to support, handhold, signpost, tackle stigma, and hopefully that will start to hopefully build confidence within the community to start reaching out. Other things quickly is about the organisations that are currently working on these on mental health. So the mental health trusts, for example, or the CCG clinical commission groups, they need to have those trusted voices, as Gersh has already mentioned, and others, trusted voices from the communities to be able to bridge that gap between the communities. And again, faith leaders are a great asset as well, which we need to utilise better. And specialist organisations, I keep saying ours, we're only a small organisation, but there are organisations around the country, networks, faith organisations that could be engaged as well.
Thank you very much, Kirat. Some really good examples, I guess, of how we can move forward. And I just pose this question to either Priya or Jeff. I know you took us through the research that you've done. So what would be what are the next steps to take that work forward?
You're going to respond to this one, Priya. I think it's yours. I think.
Yeah, oh, yeah, definitely. So we're looking to split the work into two strands. So one sort of focusing on developing that good practice engagement model, and then also working with sort of the local university and other universities to sort of research more around sort of inequalities within Black and Asian communities to look at specific projects there. And one sort of pilot was particularly sort of exploring is working with public health locally, the behavioural change unit, to look at messages in regards to the vaccine, as well as their sort of engage to empower conversation tool. So that's an example of something that we're doing.
Great, that sounds like good sort of steps forward. So now I just wanted to come to each member of the panel and ask a quick question around if you could just give me one sentence from you all, and I'll take you in the order that you've spoken today. What is the one thing you would change to improve health inequalities across cultural boundaries? So we start with Sandeep, please.
That's a very interesting question. I would say, I think echoing this particular session, there's a running theme around collaboration here and empowerment. So I would leave it with that, collaboration and empowerment moving forward.
Thank you. And Naina, come to you next, please.
I think it's looking at the ways that which we can empower communities and different communities within a particular ethnic group on how they can take control of their own health.
Sure, thank you very much. And Kirat.
So really, I'm just going to say our mission is engage, educate, empower, explore. And in order to get there, we need to add another E around equality. And all of that leads to better collaboration.
Thank you. And Mohammed?
I think it's about providing patients with a greater variety of tools and a variety of treatment modalities, so they can then break down those inequalities and provide equitable services. So there's equality, but it's about equity of outcome as well, and providing custom tools. So having that adaptability.
Great, thank you very much. And Jeff?
I think I would go for looking for short-term improvement, but long-term change in what people are trying to do in their work with communities. So fixing things, immediate needs, but looking at the longer term, how to get that fundamental change in those relationships.
Great, thank you. And Priya?
Yeah, so I guess what I think could be better, which echoes what everyone's really saying, is that I think things like we could have sort of better sort of tailored interventions, but based on deeper understanding, I think would be the kind of takeaway.
Thank you very much. And last but not least, Gert.
I guess my reflection is that I think nothing unique to the UK, it happens in many other countries as well, is we still have a challenge in that we, governments especially, still see communities as having a deficit model rather than an asset. So if we view communities as assets, we would want to tackle inequalities through public engagement. And that would mean that we would stop talking about these things but start acting on it.
So action, I guess, is where we're going, rather than like you said earlier on, Gert, it's not a debate. We need action now. Okay, that's great. Well, thank you very much. Can I just, we come to the end of the webinar now, and please don't forget to fill in the feedback survey. It'll just take 2 minutes of your time, and it'll help us to improve our future events and topics that you might like to see covered. Thank you very much to everyone who joined the webinar, and a huge thank you to all of our speakers that have taken the time to come and speak, and thank you to our patients for sharing their personal journey and stories with us. And we hope you can join us on another webinar in the future, and what's coming soon will be on the next slide. Thank you very much.